Welcome to today's deep dive. I'm just so glad you're here joining us today because we are embarking on a truly fascinating journey.
We really are.
Yeah, whether you are a medical student prepping for boards, a public health trainee, a junior doctor navigating hospital wards, or, just someone who is insanely curious about how we make massive decisions that affect millions of lives, you are in the exact right place.
Absolutely.
We are using the Oxford textbook of global public health as our structural spine today. But our mission isn't just to list facts or read to you from a textbook. We want to clarify critical public health frameworks, strengthen your clinical reasoning, and really support your active reading of the text.
Right. We want to look at the mechanisms, the why and the how behind public health architecture.
Exactly. Today, we are exploring two distinct but intricately interconnected pillars of public health intervention. So that's population screening and community-based trials in low- and middle-income countries, or LMICs.
And that is the core of our mission today. We are drawing specifically from Chapter 11.4, which covers population screening, and Chapter 5.10, which dives into community-based intervention trials.
Okay.
And to conceptualize how these two completely different chapters fit together, I want you to imagine public health as managing a vast, complex river system.
A river system.
Right. Your ultimate goal is to protect the vulnerable towns located far downstream. Everything we do in public health is about managing the flow of risk, exposure, and outcome along that river.
Okay, let's unpack this. If public health is a river system, then population screening is our early warning radar, or like a sonar system.
Yes.
It is a high-tech grid scanning the water, looking for hidden rocks, submerged hazards, or developing undercurrents long before they cause a massive shipwreck down by the town. It is systematic, it relies on detection, and it happens before the disaster fully materializes.
That is the perfect way to visualize it.
Yeah.
And on the other side of the equation, you have community-based interventions. If screening is the sonar, then the trials we see so often in LMICs are the upstream engineering projects.
Hey, you're building things.
Exactly. This is where you put away the radar and get your hands dirty. You are building levees, planting trees to stop erosion along the banks, or working directly with the locals who live on the river to change how they interact with the water entirely.
Wow.
Both the sonar and the upstream engineering are absolutely vital to saving the town downstream, but both come with massive logistical, ethical, and economic challenges that are completely invisible to the casual observer.
I want to keep that rut metaphor in mind throughout this entire deep dive. So we are going to start with the sonar. Let's transition into the first half of our analysis, the early warning radar of population screening.
Let's do it.
On the surface, screening sounds like the most intuitive, beautiful concept in medicine. You catch a disease early, you save a life. It's an incredibly easy sell to the public, to politicians, to patient advocacy groups. But the reality is incredibly messy, isn't it?
It is arguably one of the messiest and most misunderstood areas in medicine. To understand why, we have to start with a very rigid differentiation. We need to define what screening actually is.
And what it isn't.
And more importantly, what it is not. The foundational definition, formulated way back in 1968 and later refined by bodies like the UK National Screening Committee, is highly specific. Screening is a public health service directed at a defined population of people who presume themselves to be completely healthy.
They presume they're healthy.
Yes. The healthcare provider is the one approaching them, offering a test to identify those who are more likely to be helped than harmed by further investigation.
That distinction feels so critical because I think a lot of people, even in clinical practice, use the word screening incorrectly.
Oh, all the time.
You might hear a doctor say they are screening a diabetic patient for retinal disease or screening someone who comes into the emergency room for an infectious disease just because they are already drawing blood. But that doesn't fit the definition at all.
It doesn't. And confusing those concepts leads to terrible public health policy. What you just described is clinical testing, opportunistic testing, or case finding.
Case finding.
Let's break that down. When a patient with diabetes has their eyes checked for retinopathy, they are already deeply embedded in the healthcare system. They have a known diagnosed systemic disease that carries a high risk of vascular complications.
Right.
The doctor is managing an existing condition. When an emergency room doctor runs an extra blood panel on a patient who came in for a sprained ankle, that is opportunistic testing. The patient initiated the encounter by walking into the hospital.
So the key difference is the initiation of contact and the baseline health status of the target.
Precisely. When we talk about population screening, we mean the state or the healthcare system systematically inviting hundreds of thousands or millions of completely asymptomatic people who have not asked for medical advice.
People who are just sitting at home feeling perfectly fine.
Exactly. And asking them to undergo a medical test.
And that leads us right into what we can call the core paradox of screening. Because we are proactively intervening on healthy people who did not ask for our help, screening is one of the very few medical interventions that inevitably and unavoidably does harm to a subset of perfectly healthy individuals. We are turning healthy citizens into patients.
That is the uncomfortable truth at the heart of the radar system. If you scan 1 million healthy people with your sonar, you are going to get echoes that look like rocks but are actually just shadows.
False positives.
You'll generate false positives. You will induce severe psychological anxiety in people who were completely fine before you sent them a letter in the mail. You will subject healthy people to invasive diagnostic biopsies that carry their own real-world risks of hemorrhage, infection, or even death.
And overdiagnosis.
Yes. You will find borderline abnormalities that might never have progressed or caused a problem in that person's lifetime. But because you found it, you have turned them into a patient, subjecting them to overtreatment.
I think it was pointed out back in the early 70s that because the healthcare system is the one initiating the offer, there is an implicit promise being made to the citizen. We are basically saying, take this test, it will benefit you.
Right.
Therefore, the ethical bar for introducing a population screening program has to be astronomically high. We can't just guess that it works. We must rigorously prove that the program does more good than harm for the population as a whole.
And proving that requires an intense understanding of statistical mechanics. It requires us to abandon our clinical instincts and embrace epidemiological reality. In a clinical setting, you are dealing with a sick person sitting in front of you. In a public health setting, you are dealing with 1 million invisible people spread across a country. The rules of engagement are entirely different.
Here's where it gets really interesting. To prove it does more good than harm, we have to talk about the framework of detection, the actual properties of the screening test itself. And this is where that clinical intuition clashes so hard with public health reality.
It really does.
When you're a clinician treating a sick patient in the hospital, you are obsessed with sensitivity. You do not want to miss a true positive case. If someone comes in with chest pain, you want the most sensitive test possible so you can definitively say, I did not miss a heart attack.
It is a totally natural clinical instinct to prioritize sensitivity. Let's define it clearly for everyone listening. Sensitivity is the proportion of subjects with the target condition who are correctly classified by the test as true positives. It's your ability to catch the bad guys.
Catching the bad guys.
But in population screening, where you are testing a massive sea of healthy people, specificity becomes your most critical asset. Specificity is the proportion of disease-free subjects who are correctly classified as true negatives. It is your ability to correctly identify the healthy people and leave them alone.
Why is specificity the MVP here? Because to the general public, and even to many politicians, the idea of missing a cancer, a false negative, is viewed as the ultimate failure of a screening program. People sue over false negatives. No one sues over a false positive. They just feel relieved when the biopsy comes back clear.
That is the psychological bias we fight against. But let's look at the mathematics of prevalence. Let's imagine a town of 10,000 people.
Okay, 10,000.
You want to screen them for a rare disease that only affects 1 in 1,000 people. So in this town, exactly 10 people actually have the disease, and 9,990 people are perfectly healthy.
Got it.
Now, let's say your screening test is incredible. It has 100% sensitivity, it will catch all 10 sick people, and let's say it has 99% specificity, which sounds fantastic to a layperson.
99% specificity sounds like an A+ on a test.
It does. Let's run the math. You test the 9,990 healthy people. Because the test is 99% specific, it correctly identifies 9,890 of them as healthy. But that 1% error rate? That means 100 perfectly healthy people receive a false positive result.
Wait, let me pause and process that. You found the 10 sick people, but you also flagged 100 healthy people.
Exactly. So your clinic just sent out 110 terrifying letters telling people they might have a fatal disease. And out of those 110 people sitting in your waiting room crying, only 10 actually have the disease.
That is brutal.
This brings us to the most vital concept in screening. Positive predictive value, or PPV. Positive predictive value asks the only question the patient actually cares about. If my test comes back positive, what is the actual real-world probability that I truly have the disease?
In your town analogy, the PPV would be 10 true positives divided by the 110 total positive results. That's a PPV of about 9%.
Hmm.
That is wild.
It's sobering.
The test is 99% accurate, but if you get a positive result, there's only a 9% chance you are actually sick.
And this illustrates why PPV isn't just a fixed property of the machine doing the test, right? It relies entirely on how common the disease is in the population you are testing. The prevalence dictates the reality.
The prevalence dictates everything.
Yeah.
And the Oxford text gives a brilliant real-world example of this using beta thalassemia.
Right.
Beta thalassemia is a genetic blood disorder. The screening test often looks at mean cell hemoglobin, or MCH. They set a cutoff at 27 picograms. If your MCH is below that, you screen positive.
Okay.
In a sample taken from 2 specific London hospitals that serve a population with a very high background prevalence of the genetic trait, this test had 100% sensitivity. And because the prevalence in that specific community was so high, the positive predictive value was incredibly strong, approximately 77%. So in that high prevalence London hospital, if a patient's test flagged positive, the doctor could look them in the eye and say, there is a 77% chance you are a carrier. That is a highly useful clinical tool.
It is highly useful. But what happens if the Ministry of Health decides that because the test worked so well in those 2 hospitals, they should roll it out as a universal screening program across the entire country, including regions where the beta thalassemia trait is incredibly rare?
You take that exact same test with the exact same machine, the exact same 100% sensitivity, and you drop it into a low prevalence population. The textbook notes that when you do that, the positive predictive value plummets. It drops to anywhere between 1.3% and 30%, depending on the specific demographic area.
This raises an important question for you to consider as a clinician or a public health planner. What happens to a healthcare system when the positive predictive value drops to 1.3%?
It means total systemic collapse. It means that out of every 100 people who get a phone call saying their genetic test is positive, 98 of them are completely healthy false positives.
And think about the workload that generates. Every single one of those 98 false positives requires a follow-up appointment. They require a doctor's time to explain the result. They require confirmatory DNA testing, which is expensive and time-consuming. They require genetic counseling.
And the psychological toll.
Yes. Perhaps most importantly, it inflicts immense psychological harm on the community. People lose sleep, they miss work, they worry about their future children, all because of an echo on the sonar that was nothing more than a shadow. This is why you cannot just take a test developed in a high-prevalence, enriched hospital setting and roll it out to the general asymptomatic public without accounting for the background prevalence. False positives will absolutely drown your clinical staff and destroy the economic viability of the program.
So if you are forced to screen a low prevalence population, the only way to fix that PPV issue is to artificially increase the specificity of the test.
Yeah.
We have to tighten the net.
You do.
The text mentions that for the beta thalassemia program, they realized the simple MCH test wasn't specific enough for the general population. So they started combining the MCH test with another blood marker. In some cases, they even just added a simple, targeted questionnaire about the patient's family origins to establish pretest probability.
A very smart move.
By layering these criteria and increasing the specificity, they reduced the number of partners needing follow-up recall by 96%.
That is a phenomenal example of upstream engineering applied to the sonar itself. By tweaking the specificity criteria, they saved the system an immense amount of money and saved thousands of people from unnecessary anxiety. And that leads directly into the health economics of screening, because all of those false positives, all of that follow-up, and all of that clinical time costs money, real finite money.
This brings us to the famous Wilson and Youngner criteria from the late 60s. Let's provide some historical context here, because 1968 wasn't just a random year. This was an era when automated laboratory analyzers were first being introduced. Suddenly, hospitals had machines that could run 10 or 20 different biochemical tests on a single vial of blood almost instantly.
It was a revolution.
There was a massive push from the medical technology industry to just test everybody for everything all the time. Wilson and Youngner, working for the World Health Organization, had to step in and create a philosophical and economic dam to hold back this flood of indiscriminate testing.
It was a pivotal moment in public health history. They laid out 10 criteria that must be met before a screening program is launched. These have since been expanded, but the core principles remain. They demanded that the condition must be an important health problem. There must be a recognizable, latent, or early symptomatic stage. There must be an accepted treatment. And critically, the opportunity cost of the screening program must be economically balanced in relation to possible expenditure on medical care as a whole.
I want to pause on that term, opportunity cost, because I think this is where the public misunderstands healthcare funding. Every single dollar a government spends on mailing out screening kits, running the machines, and chasing down false positives is a dollar they cannot spend on primary care clinics, on treating patients who are currently sick in the ICU, or on building better infrastructure. It is a zero-sum game.
It absolutely is. We try to measure this value for money using metrics like QLOIs, quality-adjusted life years, and Daly's disability-adjusted life years. We build complex economic models to predict if a screening program is worth the investment. But the Oxford text makes a really striking point that should serve as a warning to anyone reading it. Pre-assessments of screening costs are almost always vastly underestimated. We consistently get the math wrong before we launch these programs.
Why is that? Are the economists just bad at their jobs, or is the river system just too complex to model accurately?
It's the complexity and the massive time horizons involved. You are trying to model clinical benefits and population dynamics that might not materialize for decades. By the time you actually implement the program, the world has fundamentally changed. The textbook gives a brilliant classic example of this with abdominal aortic aneurysm, or AAA screening.
An abdominal aortic aneurysm is a swelling of the main blood vessel that leads away from the heart down through the abdomen. If it ruptures, it is catastrophic and often fatal. So catching it early with a simple ultrasound seems like a great idea.
And they ran randomized controlled trials to prove it. But those trials were planned and conducted during an era when smoking rates were much, much higher. Smoking is a massive primary risk factor for developing an aortic aneurysm. So the health economists built their cost-effectiveness models assuming a high background prevalence of AAA based on the data from the trials.
But then the upstream engineers went to work. Public health campaigns, taxation, advertising bans, they successfully drove down smoking rates across the population over the next couple of decades.
Exactly. The background prevalence of AAA plummeted. So by the time the AAA screening program was actually rolled out nationally years later, the disease landscape had transformed. The ultrasound screening program was finding far fewer aneurysms than the models predicted. You were still paying for all the ultrasound machines, all the technicians, and all the administrative overhead, but your catch rate was a fraction of what was expected, throwing off the entire cost-effectiveness calculation.
That is a perfect illustration of why public health requires systems thinking. You cannot evaluate the early warning sonar without looking at what the upstream engineers are doing with tobacco policy. If you change the flow of the river, your sonar readings are going to change. And beyond changing prevalence, there are the hidden operational costs. People think the cost of a screening program is just the cost of the plastic test tube, or the chemical reagent, or the MRI machine itself.
That is the great illusion of medical procurement. The machine is the cheapest part. The hidden costs are monumental because you aren't just buying a piece of equipment, you're building an entire industrial system from scratch.
Right.
You need to hire thousands of specialized nurses, technicians, and doctors who require continuous training and certification. You need massive IT infrastructures to manage call and recall systems, databases that track millions of citizens, ensuring they get their invitation letters on their 50th birthday, and ensuring no one falls through the cracks if they miss an appointment. You need robust quality assurance bodies, external inspection schemes, and fail-safe mechanisms to audit the program constantly.
And from a broader societal perspective, there are costs that don't even show up on the Ministry of Health ledger. You have the hidden economic cost of patients taking days off work to attend a screening. You have the lost productivity when a patient suffers severe anxiety from a false positive and schedules 3 extra visits to their general practitioner just for reassurance. When you factor all of this in the IT, the staffing, the anxiety, the unnecessary biopsies, a program that looked incredibly cheap in a tightly controlled small-scale trial suddenly becomes a massive, voracious drain on national health resources.
Which brings us to a really thorny area, the ethics of unsolicited intervention. Screening is far from a neutral, objective scientific pursuit. It is heavily political and deeply value-laden. Let's look at the tension between equity and efficiency. This is where the math collides with human emotion. Let's explore that. From an efficiency standpoint, which is a utilitarian view focused on achieving the greatest good for the greatest number with limited resources, we should only target screening at specific demographics where the prevalence is high enough and the test is accurate enough to justify the cost. But from an equity standpoint, this causes massive friction. If you screen one group but not another, people feel disenfranchised. They feel abandoned by the state. The most prominent and contentious example of this is the ongoing debate around prostate cancer screening. In many high-income countries, there are highly organized, heavily funded national screening programs for breast cancer and cervical cancer. These programs invite women at specific ages for routine mammograms or smear tests. Consequently, some men's advocacy groups argue that fairness dictates there should be an equivalent national population-based screening program for prostate cancer. They view the lack of such a program as a glaring gender inequity.
But the efficiency data, the hard epidemiological evidence, doesn't support population-wide prostate screening. It's not that we don't care about prostate cancer, it's that the sonar is flawed.
Exactly. Well, prostate cancer is very common. The current screening tool, the prostate-specific antigen, or PSA blood test, lacks the necessary specificity and positive predictive value for population-wide asymptomatic screening. It generates a massive amount of overdiagnosis. The clinical reality is that many men die with prostate cancer, not of it. It is often a very slow-growing tumor in older men.
And screening finds all of those slow ones.
It does. If you aggressively screen millions of asymptomatic men, you will find a lot of elevated PSA levels. That leads to thousands of unnecessary transrectal biopsies, which carry risks of severe infection. It leads to radical prostatectomies and radiation therapies for tumors that never would have caused symptoms in the patient's lifetime. And those treatments carry high risks of permanent incontinence and impotence.
So you are taking a healthy 65-year-old man, finding a sluggish tumor that wouldn't have killed him, treating it aggressively, and leaving him incontinent for the rest of his life without actually extending his lifespan.
That is the stark reality. So the state is caught in a profound ethical bind. Do you implement a national screening program to satisfy a political demand for perceived equity and fairness, even when the epidemiological data overwhelmingly tells you that the program will cause net harm to the male population? Public health officials have to be the stewards of evidence, even when it is deeply unpopular.
And when individuals are offered these tests, we talk a lot about informed choice. Marto defines informed choice as a decision based on relevant knowledge, consistent with the decision maker's values, and behaviorally implemented. But let's be honest about the reality of a clinical encounter. How can any citizen truly give informed consent when the statistics of population screening are so mind-bendingly complex?
It is a monumental challenge. It is arguably impossible for the average citizen to fully grasp the statistical nuance in a 10-minute consultation with their doctor. Take the concept of the number needed to screen. This is a vital metric. To prevent one single death from breast cancer, statistical models indicate you might need to screen roughly 2,451 women between the ages of 50 and 59 repeatedly over a 5-year period.
Yeah, let's just sit with that number for a second. 2,451 women need to go through the process to save one life.
Yes, and in the process of screening those 2,451 women over 5 years, you will inevitably generate hundreds of false positives. Hundreds of women will endure the terror of being recalled, the physical pain and risk of biopsies, and immense psychological distress, only to find out they are fine. Communicating that complex risk-benefit ratio, explaining to a patient that taking the test is statistically much more likely to cause them unnecessary anxiety and harm than it is to save their life is incredibly difficult.
Especially when the media, celebrity campaigns, and private diagnostic clinics are constantly bombarding them with the simplified narrative that early detection saves lives. It's a catchy slogan, but it ignores the collateral damage. The textbook uses the term stewardship to describe the state's role here. Because true, statistically literate informed consent is so hard to achieve at an individual level, democratic states take on the stewardship role. They use centralized committees to make these complex efficiency decisions for the population, acting as a buffer to protect citizens from predatory testing markets that just want to sell scans.
And we must tread with extreme caution when the state assumes that stewardship role, particularly regarding reproductive or genetic screening. History casts a very long, very dark shadow over this area. The textbook explicitly and necessarily mentions the history of eugenics. This was the early 20th century movement, peaking in its absolute horrors during the Nazi period, that sought to improve human hereditary traits through state intervention, forced sterilization, and murder.
A terrifying precedent.
Today, as we rapidly expand newborn blood spot screening and prenatal genetic testing, we are offering parents informed reproductive choices. But the echoes of state-sponsored selection require us to maintain the highest possible ethical boundaries. These programs must remain strictly voluntary, driven by parental choice, and heavily scrutinized to prevent any structural stigmatization of individuals living with genetic conditions or disabilities. The framework must be about offering information for management, never about state-directed population control.
It is a sobering reminder of the power these tools hold. So we have all these complexities. We have the false positives, the massive economic burdens, the ethical hurdles of stewardship. And yet, the textbook points out a fascinating phenomenon. Once a screening program starts, even if later evidence proves it is harmful, it is almost impossible to stop. The researchers Raffel and Gray coined a brilliant term for this, the popularity paradox. I find this absolutely fascinating.
It is one of the most counterintuitive phenomena in public health. The popularity paradox states that the more a screening program overdiagnoses and overtreats healthy people, the more fiercely popular and politically untouchable that program becomes.
If we connect this to the bigger picture of human psychology, it actually makes perfect sense. Walk us through the psychology of overdiagnosis.
Imagine a screening program that uses a very sensitive but poorly specific test. It detects a huge number of harmless, slow-growing, indolent abnormalities that never would have caused symptoms or threatened the patient's life. The program finds these abnormalities, labels these healthy people as cancer patients, and aggressively treats them with surgery, chemotherapy, or radiation. Every single one of those people survives because the abnormality was never going to kill them in the first place. But they don't know that. They genuinely believe that the screening program caught their cancer early and saved their life.
So they become fierce, passionate, deeply emotional advocates for the program. They start charities, they lobby politicians, they speak to the media saying, "This scan saved my life, we must test everyone."
Precisely. The tragic irony is that the failure of the test, its tendency to overdiagnose harmless lesions, actually builds its political armor. The more harm the program does by turning healthy people into unnecessary patients, the larger its army of loyal, vocal survivors grows.
That is profound. The defect in the sonar is what makes people worship the sonar. And stopping a program that has that kind of entrenched emotional public support requires immense political courage, because anyone who tries to stop it will be accused of letting people die.
It is a political nightmare. The textbook provides two stark examples of the difficulty of stopping programs. Let's look at Denmark. In Denmark, they had a mandatory chest X-ray screening program for tuberculosis. It made sense in the mid-20th century. But it took 20 years after tuberculosis was essentially eradicated from the Danish population before they finally stopped the mandatory X-rays. For 2 decades, they were exposing their citizens to unnecessary, cancer-causing radiation for zero epidemiological benefit, simply because the screening infrastructure was an entrenched bureaucratic system that no one had the momentum to dismantle.
But Japan had a success story in stopping a program, didn't they?
Yes, the Japanese neuroblastoma screening program is a classic case study. Neuroblastoma is a rare tumor of the sympathetic nervous system that occurs in young children. In 1985, Japan started a massive nationwide program screening infants at 6 months of age using a urine test for specific catecholamines. They screened millions of babies, they found tumors, and they surgically removed them. But by 1990, epidemiological data started rolling in. An international panel reviewed the evidence and concluded that the screening program did not actually reduce the mortality rate from neuroblastoma at all. Instead, it was resulting in severe harm through the overdiagnosis and surgical overtreatment of tumors that likely would have spontaneously regressed on their own.
So they were doing surgery on babies for tumors that would have just vanished.
Exactly. And in 2004, the Japanese government achieved something incredibly rare. They successfully shut down the national program. Why did they succeed where others fail? Because, unlike adult cancer screening, there was very little organized parental demand for the test. The medical media responsibly supported the scientific evidence rather than sensationalizing it. And crucially, because it was screening infants, there is no entrenched vocal advocacy group of adult survivors fighting to keep it going. It was a victory for evidence-based de-implementation.
To really understand why overdiagnosis happens and why programs like the Japanese neuroblastoma screening fail to reduce mortality despite finding tumors, we need to clarify two highly tested foundational epidemiological concepts. Lead time bias and length time bias.
Yeah.
These are the twin illusions of screening efficacy. Every medical student listening needs to know these cultures.
Let's differentiate them clearly because they explain why catching a disease early doesn't always mean the patient lives longer. Let's start with lead time bias. Lead time bias is the illusion of living longer.
Let's use an analogy here. I like to think of lead time bias as seeing a rock on the sonar, but realizing your boat's rudder is broken. You know you're going to hit the rock earlier, but you still can't steer away from it any faster.
That's an excellent way to conceptualize it. Let's map it onto a patient. Imagine a patient who has a disease. Without any screening, this disease would naturally cause physical symptoms when the patient reaches age 60. They go to the doctor at 60, get diagnosed, but the disease is incurable, and they die at age 65. Their survival time from the moment of diagnosis is 5 years. Now imagine we introduce a screening program. The program detects that exact same disease in that exact same patient at age 55, 5 years before symptoms would have appeared. But here's the catch. The medical intervention we have doesn't actually alter the natural biological course of this specific disease. Despite the early treatment, the patient still dies at exactly age 65.
So the outcome didn't change at all. But if you look at the statistics,
If you look at the screening program's statistics, the survival time from the point of diagnosis is now 10 years. It looks like the screening program doubled their survival time. The politicians will cheer. But it didn't extend their life by a single day. All the screening program did was force that patient to live 5 extra years with the agonizing knowledge and anxiety that they had a fatal disease. It advanced the time of diagnosis, but not the time of death. That is lead time bias.
and then there's length time bias, which is the illusion of catching the bad actors. I always think of this as the turtle and rabbit bias.
The turtle and rabbit analogy is perfect for length time bias. This bias occurs because screening programs take intermittent snapshots of the population, say a mammogram every 3 years or a colonoscopy every 10 years. Now, imagine diseases, particularly tumors, as either rabbits or turtles. Aggressive, rapidly fatal, highly malignant tumors are the rabbits. They grow incredibly fast. They often appear, cause symptoms, and unfortunately kill the patient in the brief interval between scheduled screenings. The screening program misses them because they are too fast.
And the turtles.
The turtles are the slow-growing, indolent, or even benign tumors. They stay in the body for years and years without doing much. Because they are present in the body for such a long duration, it is highly likely that whenever the screening snapshot occurs, it will catch the turtles. Therefore, the screening program disproportionately detects the slow-growing turtles and misses the fast-growing rabbits.
So when researchers look back at the data, the people whose cancers were caught by the screening program have incredibly high survival rates compared to people whose cancers appeared symptomatically between screenings.
Exactly. But this isn't because the screening intervention saved them. It's an illusion. It's simply because the screening mechanism fundamentally selects for cancers that weren't going to kill the patient quickly anyway. The program looks wildly successful, but it's just a statistical artifact of the tumor's natural biology.
Okay, that is a masterclass in the pitfalls of screening. We've mapped the sonar. We see how difficult it is to accurately ping the hazards without causing mass panic, wasting finite resources, and generating the illusions of lead time and length time bias. So what does this all mean for the rest of public health? Let's transition to the second half of our deep dive. We are leaving the high-tech macro policy world of national sonar systems, and we are traveling up the river. We are looking at upstream engineering, community-based intervention trials, specifically in low and middle-income countries, drawing from Chapter 5.10.
The shift here is profound. When you move from population screening in high-income countries to community trials and LMICs, the entire operational landscape changes. Historically, high-income countries develop these community-based interventions primarily to tackle cardiovascular disease and chronic lifestyle factors. But in the late 80s and early 90s, public health pioneers adapted these methods for LMICs. Initially, the focus was overwhelmingly on the acute burdens of the time, infectious diseases like HIV and malaria, childhood mortality, and maternal health.
But the textbook notes a fascinating shift occurring right now due to the epidemiological transition. As LMICs develop economically, they are facing a double burden of disease.
They are, and so the trials are expanding rapidly. We still see massive trials for malaria bed nets, but increasingly researchers are designing community interventions for non-communicable diseases in resource-limited settings. We see complex trials addressing childhood obesity in urban Chile, mental health daycare programs for the elderly in rural India, and community-based blood pressure control in sub-Saharan Africa.
But doing a trial in a rural village in Tanzania or an informal settlement in Nepal is radically different from running a clinical trial in the sterile hospital in London or Boston. It is the ultimate exercise in innovation under intense constraint. You often don't have a formal, rigid healthcare system to plug your intervention into. You rely heavily on community mobilization, non-governmental partnerships, and informal health networks. You're working with traditional birth attendants in Nepal or training informal food market vendors in China.
And that environmental constraint forces researchers to think deeply and creatively about trial design. Let's contrast it with a standard clinical trial. In a clinical trial testing a new blood pressure pill, you randomize individual patients. Patient A gets the active drug, patient B gets the sugar pill placebo. It is neat, isolated, and statistically pure. But in public health, the intervention is rarely a pill. The intervention is often a fundamental change to the environment, a mass media education campaign, or a change in community social norms.
You cannot easily give half a village a radio broadcast about sanitation and magically shield the other half of the village from hearing it. It's impossible.
Exactly. Therefore, the unit of randomization can no longer be the individual person. It must be the community.
But how do you even define a community in these trials? Because it's not always just a town with a border drawn around it on a map.
It is highly contextual and depends entirely on how the intervention is delivered. A community is usually defined along geographical, social, or administrative lines that make logistical sense for the intervention. For example, in a massive trial providing vitamin A supplementation in Nepal to reduce childhood mortality, the community was defined as a ward, which is a specific, pre-existing administrative subdistrict. The local political boundaries dictated the trial boundaries.
And what about other contexts?
In a maternal awareness and health study in Guatemala, they randomized entire vast regions. In a highly specialized trial aimed at preventing ventilator-associated pneumonia, the communities weren't towns at all. They were intensive care units within adult and pediatric hospitals across multiple countries. The ICU was the community. And perhaps most uniquely, in the NIMH Collaborative HIV and STD Prevention Trial, the defined community was literally specific. Physical food markets where vendors congregated to sell their goods.
Let me play devil's advocate here. Randomizing whole communities sounds like a massive logistical headache. It requires thousands of people, huge coordination, and complex math. Why go through all that? Why not just bite the bullet, go into a single village, and randomize individuals within that village to receive the health education or not?
Two words dictate that decision: contamination and feasibility. If you randomize individuals within a highly interactive, tightly knit community to receive an educational intervention, say, counseling on the importance of exclusive breastfeeding, what do you think those mothers are going to do?
They are going to talk to their neighbors, they're going to share the good advice at the well or the market.
Exactly. The control group will inevitably learn the information from the intervention group. The intervention spills over. This dilutes the measurable effect between the two groups, a methodological disaster we call contamination. We saw a prime example of this in an intervention designed to promote consistent condom use among female sex workers in China.
Let's talk about the China study because it perfectly illustrates the concept of contamination.
The researchers initially tried to randomize specific entertainment establishments, bars, or clubs to receive the intervention or act as controls, but they failed to account for the sociology of the population. The sex workers were highly mobile. They moved fluidly and constantly between different establishments, sharing information, experiences, and the condoms themselves. Any knowledge or behavior change gained in an intervention venue was immediately carried into and shared within the control venues. Contamination was absolute. The control group adopted the intervention behaviors, making it statistically impossible to measure the true effect of the program.
So, to build a dam against contamination, use cluster randomization. You assign whole geographically separated communities clusters to either the intervention arm or the control arm. If Village A gets the education, Village B, which is 50 miles away, acts as the control. But earlier you mentioned that this introduces a major statistical headache. Why is cluster math so much harder than individual math?
Because it violates a core assumption of standard statistics, the independence of observations. People who live in the same village are not statistically independent. They share the same water source, they go to the same under-resourced clinic, they are exposed to the same local pathogens, and they share similar cultural and dietary practices. Therefore, two individuals selected at random from the same village are likely to be much more similar to each other in terms of health outcomes than two individuals selected from different villages.
They are correlated.
Precisely. This phenomenon is quantified by a metric called the intra-cluster correlation coefficient, or ICC. Because the data from individuals within a cluster is correlated, you lose statistical power. You don't have as many independent data points as you thought you did. To compensate for this hidden similarity, you have to multiply your standard individually randomized sample size by an inflation factor, which we call the design effect.
Let's make that concrete. What does the design effect actually do to a trial's budget and logistics?
It explodes them. Essentially, if your statistician calculates that the intracluster correlation in your villages results in a design effect of 1.2, it means you cannot just recruit 1,000 people. You must recruit 20% more individuals, 1,200 people, just to achieve the exact same statistical power you would have had if you could have done an individually randomized trial. Often, the design effect is much higher, requiring you to double or triple your sample size. This means more villages, more staff, more vehicles, and vastly more funding.
So these trials require a massive scale. And to manage that variance between different villages, because one village might be near a main highway and relatively wealthy, while another is deep in the mountains, and impoverished researchers use techniques like matching and stratification before they randomize. Let's look at the three landmark African HIV and STD trials: Mwanza, Masaka, and Rakai. These are legendary in global public health literature. Every student reads about them.
They are foundational texts for trial design. In these massive cluster randomized trials, researchers needed to ensure that the group of intervention communities and the group of control communities were essentially comparable at the start of the study. In Mwanza, which is in Tanzania, and Masaka, in Uganda, the communities selected for the trial had a lot of baseline variance. Some had high STD rates, some had low, some were near truck stops, some were isolated.
So if you just flipped a coin for each village, you might accidentally put all the high-risk truck stop villages in the control group, ruining the comparison.
Exactly. So to prevent that, the researchers used matching and stratification. They essentially looked at the baseline data and paired up communities that were highly similar, pairing a truck stop village with another truck stop village, a farming village with a farming village. Then, within each matched pair, they flip the coin. One gets the intervention, one gets the control. This successfully reduced the between-community variance and drastically improved the statistical power of the studies.
But the textbook points out that the Rakai trial, also in Uganda, took a different approach. Why didn't they match?
The Rakai researchers explicitly selected a set of communities that were naturally, inherently incredibly homogeneous. Geographically, economically, and epidemiologically, the communities were almost identical from the start. Because the communities were already so similar, applying mathematical matching techniques wouldn't have reduced variance any further. In fact, in statistics, unnecessary matching actually reduces your degrees of freedom in the final analysis, which can paradoxically decrease your statistical power. The Rakai example is a brilliant lesson. Trial design cannot be blindly copied from a textbook. It must be meticulously mathematically tailored to the specific sociological and geographic reality of the landscape you are working in.
Let's talk about the measurement dilemma. We've got our clusters randomized, we understand the math. Now, how do we actually track the people to see if the upstream engineering worked? The textbook lays out two fundamental choices for longitudinal measurement: the cohort design or the repeated cross-sectional design.
This is a critical differentiation focus for anyone designing a trial. Let's start with the cohort design. In a cohort study, you go into the village at baseline and you enroll a specific named group of individuals, you take their measurements, and then you track and follow those exact same specific people over months or years. The statistical power of a cohort is superb because each person acts as their own baseline control. You can see exactly how much John or Mary changed over time.
The textbook uses the trial addressing childhood obesity in Chile as an example of this. They measured the exact same children's adiposity indices, their body fat and BMI at baseline, and then tracked those specific kids down to measure them again at a 6-month follow-up.
And for a school-based intervention where children are a captive audience, a cohort works beautifully. But in many LMIC community settings, cohorts are incredibly fragile.
Why are they fragile? What breaks a cohort?
Life breaks them. They suffer heavily from attrition. In resource-limited or agriculturally dependent settings, people migrate for work. They move away, they drop out of the study, or they simply refuse to do the follow-up interviews. And this introduces a dangerous concept: selection bias. The people who faithfully stick around to be tracked for 3 years are likely the most stable, most health-conscious people in the village. They might not be representative of the wider, perhaps more marginalized, highly mobile community that actually needs the intervention the most.
Furthermore, doesn't repeatedly testing the same people alter their behavior?
It absolutely does. It's an observer effect. If you have a control group and you visit them every 6 months to survey them about their diet or sexual habits, that survey acts as an intervention in itself. The control group might change their behavior simply because you keep asking them questions about it, which again dilutes the measured effect of your actual intervention.
So if a cohort is too fragile or risks the observer effect, the alternative is the repeated cross-sectional design. How does that differ?
It's a completely different sampling philosophy. Instead of tracking specific individuals, you treat the community as a bucket. At baseline, you reach into the bucket and pull out a random sample of people, test them, and put them back. Then, 2 years later at follow-up, you reach into the bucket again and pull out a completely different random sample of people from the same community. You compare the average of the first sample to the average of the second sample.
That seems fantastic for highly mobile populations where tracking individuals is impossible.
It is. It's also the only valid way to evaluate a mass media campaign. For example, the text discusses an intervention in Burkina Faso. They distributed anti-parasitic drugs for schistosomiasis, but they paired it with a massive national TV and radio campaign to educate the public about water hygiene. You cannot track a specific cohort of individuals for a national radio broadcast anyone might tune in at any time. So they use repeated cross-sectional surveys, interviewing different random slices of the population over time to measure the macro-level shift in knowledge and behavior across the country.
But whether you use a cohort or a cross-sectional design, you inevitably run into the problem of what you are actually measuring. As clinicians, we'd love to measure hard endpoints. We want to measure actual mortality or biological disease incidence. Did fewer people die? Did fewer people get infected? But in a resource-limited setting, that is often astronomically expensive or logistically impossible.
It is often impossible. Imagine trying to biologically test 50,000 people for a rare disease every year in a region with no paved roads and no cold chain storage for blood samples. It can't be done. This constraint forces researchers to rely on surrogate or intermediate outcomes. Instead of measuring how many people contracted HIV, which requires massive continuous blood testing, you measure how many people report using a condom. You measure behavior, knowledge, or attitudes instead of biology.
But here's the glaring flaw with surrogate behavioral outcomes. People lie. Or, to put it more generously in academic terms, they suffer from social desirability bias. If a nice researcher from a famous university comes to your village and asks if you are washing your hands after using the latrine, you're going to say yes, even if you aren't, because you know it's the right answer.
Social desirability bias is the bane of behavioral research, and this is why the most rigorous public health trials demand biological verification. You cannot just take self-reported data at face value if the stakes are high. If you are relying on self-reported condom use as your surrogate outcome for an HIV prevention trial, you must run biological spot tests for high-incidence, easily detectable STDs like syphilis, gonorrhea, or chlamydia in a subsample of the population.
It's an audit of their behavior. If the self-reporting condom use shoots up to 90%, but the biological incidence of gonorrhea remains completely flat, your surrogate outcome is failing you. The intervention didn't work, the community just learned what to say on the survey.
Exactly. And navigating that gap between what a community says and what a community does brings us to the absolute bedrock of LMIC trials: community engagement. The textbook makes it unequivocally clear. In these settings, community engagement is not a polite option. It is the structural foundation of the science. If you do not intimately understand the cultural, political, and social dynamics of the community, your intervention will fail.
If we connect this to our overarching metaphor, you cannot effectively engineer a river if you don't ask the local fishermen how the water flows during the spring floods. You will build a levee in the wrong place.
That is precisely it. And building that knowledge requires intense qualitative pre-work. Long before the first statistical model is drawn up, anthropologists, sociologists, and public health workers must be on the ground. The text provides a fascinating example of a study targeting Lao Kathoi, which are transgender women in Laos. The researchers didn't just walk in and hand out surveys. That would have failed completely. Instead, they spent weeks mapping the specific venues, the streets, and the peak hours where the community congregated. They built a valid, culturally sensitive sampling framework based on ethnographic mapping before they did any epidemiology.
The NIH HIV and STD trial did something similar, right?
They did. Anthropologists literally sat in the informal food markets from 6 a.m. to 6 p.m., just quietly observing the social networks. They mapped who talked to whom, who held influence, and who the community naturally respected. They used this ethnographic data to figure out which specific vendors were the natural, popular opinion leaders who could be trained to spread the health intervention organically through the market's gossip network. You cannot find that in a database. You have to sit in the market and watch.
And part of that engagement, ethically mandated by institutional review boards, is the creation of a community advisory board, or CAB. But the textbook is very honest here. The sanitized, idealized reality of a CAB in an ethical guideline document is often vastly different from the messy reality on the ground.
The textbook's discussion of the Tanzania CAB is a perfect cautionary case study in cultural translation. The international ethical guidelines dictate that a trial must have community representation to protect the subjects. So the researchers went to the village in Tanzania and asked the existing village leaders to recommend individuals to sit on the CAB.
Which sounds completely reasonable and respectful of local hierarchy.
It sounds reasonable, but the researchers failed to anticipate the political instincts of the local hierarchy. The village leaders simply appointed themselves to the board. The result was an almost entirely male advisory board composed of political elites who had their own local power motives. And here is the critical problem: they were trying to oversee a trial that was largely targeting women, addressing maternal and child health.
So you have a board of male politicians overseeing a maternal health study.
Yes. Attendance by the CAB members was abysmal because they were busy with other political matters. Training them on research ethics was compromised. The CAD actually hindered the study rather than helping it. It powerfully illustrates that exporting a Western ethical construct like a democratic advisory board into a different cultural, patriarchal, and political hierarchy requires deep, nuanced adaptation. You can't just check a box on an ethics form.
Let's stay on the topic of ethics for a moment, because LMIC trials present incredibly unique moral complexities that you just don't face in Boston or London. Think about informed consent. How do you get informed consent from a participant when your intervention is a radio broadcast playing across the entire valley? You can't ask everyone to sign a form before they turn on their radio.
You can't. The IRB has to grant a waiver of individual consent for the intervention itself, while maintaining strict consent requirements for any data collection or surveys. But an even deeper ethical trap in LMICs is the issue of incentives and coercion. In a high-income country, if you ask someone to spend 2 hours filling out a survey, you might compensate them with a $50 gift card. It's a token of appreciation. But in a profoundly low-income setting, the context changes entirely.
Right, because if you offer $50 in a setting where that is a month's wages, it's no longer a token. It's an overwhelming financial inducement.
It becomes coercive. People will consent to risks they would otherwise reject just to get the money to feed their family. But conversely, researchers often provide basic goods, food staples, washing powder, or basic household consumables as a culturally appropriate thank you for participation. But it's a razor-thin ethical line. Is it coercive to offer food to a hungry population? Or is it an unethical, exploitative abuse of their time and data if you don't offer them anything in return?
And then there's the ultimate ethical dilemma of the control group. How do you scientifically justify withholding a potentially life-saving or life-improving intervention from half the villages, just so you have a baseline to compare against?
That is the burden of proof. If we knew the intervention worked perfectly and caused no harm, it would be unethical to withhold it. But we don't know, which is why we do the trial. However, the textbook mentions an elegant compromise solution often used in structural interventions: the waitlisted control or stepped wedge design.
How does a waitlisted control work?
In a South African trial that combined microfinance loans with gender training to reduce intimate partner violence, the researchers and the ethics board agreed they couldn't ethically deny the control group access to economic empowerment forever. So they randomized villages to receive the intervention immediately, while the control villages were placed on a guaranteed wait list to receive the exact same intervention 3 years later after the initial data was collected. This preserves the scientific validity of the control group while ensuring eventual equitable access to the intervention for everyone involved.
Okay, we are coming to the final hurdle. We design a brilliantly matched cluster randomized trial. We engage the community deeply. We navigate the ethical minefields of coercion. And after 3 years, we get a statistically significant result. The intervention worked. Now what? Now we have to scale it up to the whole country. And this is where the difference between efficacy and effectiveness becomes the most important conceptual framework in the room.
This is where so many global health dreams go to die. Let's clearly differentiate these two concepts because they are often confused. Efficacy asks a very narrow scientific question. Does this intervention work under ideal, highly funded, strictly controlled trial conditions, staffed by the best university doctors, with infinite logistical resources and perfect compliance?
It's the laboratory test.
Yes. Effectiveness, on the other hand, asks the messy, real-world question. Does this intervention still work when we roll it out to a rural government clinic staffed by overworked, underpaid local nurses, when the foreign donor money runs out, the supply chain breaks down, and the Ministry of Health has to pay for it out of a constrained national budget?
The textbook gives us two contrasting examples of this transition from efficacy to effectiveness. The Mwanza STD trial was an incredible example of effectiveness and cost-effectiveness scaling beautifully. They proved that using a syndromic management approach to treat STDs, treating patients based on their symptoms rather than waiting for lab tests, could significantly reduce HIV incidence in the community. And when they ran the health economics on it, it cost about $10 per daily saved.
$10 per disability-adjusted life year saved is an incredible metric. It makes the intervention highly cost-effective, comparable to the value of basic childhood immunizations. Because it was cheap, relied on simple algorithms, and didn't require complex lab equipment, it was highly sustainable for national scale-up. It proved effective in the real world.
But then you look at the Honduras primary care trial. This is a masterclass in the bureaucratic barriers to scale up. Let's tell the Honduras story, because it perfectly illustrates the limits of biological efficacy.
The researchers in Honduras designed a trial to test two different interventions aimed at increasing the utilization of primary care services for mothers and children. The first intervention was giving direct, conditional monetary incentives to households if they used the clinic. The second intervention was transferring financial resources directly to the local decentralized health teams so they could improve the clinic's quality and outreach.
So empower the mothers with cash and empower the local clinics with direct funding. Sounds like a solid upstream engineering plan. What happened?
The trial proved that transferring resources to the local teams was theoretically efficacious. When the researchers did it, it improved outcomes. But when the trial ended and they tried to transition this model to the national government to do it under programmatic real-world conditions, it completely failed. It wasn't a biological failure, it was a legal and bureaucratic failure.
Why did it fail?
Because the centralized Ministry of Health in Honduras had rigid legal frameworks regarding how money could be spent. The legal mechanism required to bypass the central government and transfer state funds directly to decentralized, local health teams was legally impossible to execute at scale within their constitution and bureaucratic rules. The money couldn't move.
That is the ultimate public health lesson right there. A perfectly designed, biologically sound upstream engineering project is entirely useless if the local zoning laws won't let you pour the concrete. Feasibility, legal structure, and real-world effectiveness always trump pure theoretical efficacy.
Exactly. Global public health is not just epidemiology and biostatistics. It is politics, economics, sociology, legal frameworks, and dirt road logistics all tangled together. If you ignore any one of those threads, the intervention fails.
What an incredible sprawling journey through the Oxford text. We've gone from the mathematical paradoxes of macro-level population screening, navigating the illusions of lead time bias, all the way to the dirt road logistics of community trials in Honduras and Tanzania. Before we move to our rapid recall questions, I want to leave you with a final provocative thought to mull over on your own as you continue your studies. If global public health is a river system, and we now have the rapidly advancing technology to map the entire genome of a newborn, creating the ultimate hyper-specific molecular screening radar, and we simultaneously have the digital connectivity to reach the most remote villages on Earth with instantaneous information and mobile banking, how will the definition of community change? When geographic borders, physical villages, and local hospital catchments no longer dictate our shared health risks or our social networks, how will we design a cluster randomized trial 10 years from now? In a hyper-connected, genetically mapped world, perhaps the upstream is no longer a physical place on a map. Perhaps the upstream is everywhere.
That is a deeply fascinating concept to consider as a field rapidly evolves. Now, let's transition to our learning reinforcement. We are going to test your active recall of the critical frameworks we've discussed today. This is essential for consolidating the knowledge. I will ask a question, and I want you to actively retrieve the answer in your head. Take a second after each prompt to formulate your response before I give the answer. Prompt 1. In the context of population screening test performance, which metric relies heavily on the underlying prevalence of the disease in the target population, often causing massive issues when a test is moved from a hospital to the general public. Take a second.
The answer is positive predictive value, or PPV. As disease prevalence drops in the general population, PPV drops precipitously, drastically increasing the ratio of false positives. You can revisit Chapter 11.4, specifically the section on properties of screening tests, for more detail on this mathematical relationship.
Prompt 2. A national cancer screening program is heavily criticized by epidemiologists because it disproportionately detects slow-growing, indolent, benign tumors, the PIRTLs, while entirely missing aggressive, rapidly fatal ones, the rabbits, that emerge between screening intervals. What specific type of bias does this represent? Take a second.
The answer is length time bias. You can deeply review this concept in Chapter 11.4 under the Cancer Screening in Adults section.
Prompt 3. Why is individual randomization almost always avoided in community-based intervention trials that utilize mass media, health education, or changes to local social norms? Take a second.
The answer is to avoid contamination. Individuals in the control group might easily be exposed to the intervention through local social networks, conversation, or travel, thereby adopting the behavior and diluting the measured statistical effect of the trial. This is covered thoroughly in Chapter 5.0, section on the comparison group and randomization.
Prompt 4. What specific statistical phenomenon occurs because individuals living within a shared environment, like a specific village, are more similar to each other than to individuals in a different village, requiring researchers to use a design effect to increase the trial's sample size? Take a second.
The answer is intracluster correlation. This lack of statistical independence between neighbors requires a larger sample size to achieve power. Revisit Chapter 5.NIS, section on sample size and statistical power.
Prompt 5. In public health scale-up, what is the fundamental difference between measuring efficacy and measuring effectiveness? Take a second.
The answer is efficacy measures an intervention's biological impact under ideal, highly funded, strictly controlled scientific conditions. Effectiveness measures its impact under real-world, programmatic, often legally and resource-constrained conditions. This vital distinction is detailed in Chapter 5.NIN, Translating Scientific Studies to Program Settings.
Prompt 6. What term describes the psychological and political phenomenon where public support for a screening program remains fiercely high precisely because of the huge number of healthy people who were unnecessarily overdiagnosed and treated, falsely believing the program saved their lives? Take a second.
The answer is the popularity paradox. You can find this fascinating dynamic discussed in Chapter 11.4, section on evaluating, restricting, and stopping existing programs. Here are the details of this episode.
Community-based intervention trials in low- and middle-income countries. Byline. Innovation under constraint testing prevention where systems are evolving.